Hello and welcome to ASAP's Best Practices in Advanced NSCLC Project Echo video conference series. Today's session focuses on key actionable driver mutations in patients with advanced NSCLC. And my name is Dara Oken, and I'm a learning experience designer at ASCP. I will be facilitating today's session. Copy of the disclosures can be seen on the screen. In addition, today's session is funded by independent educational grants from Janssen Biotech, Inc., administered by Janssen Scientific Affairs, LLC, and by Pfizer, Inc. Please note that this video conference is being recorded, and by participating, you're agreeing that ASAP may use the recording of your image and statements on ASAP's website and YouTube channel. Before we get started, let's take a moment for introductions. Please type in your name, title, and institution into the chat. We have people from all over the world tuning in. It'd be great to know who is here. Okay, well, great to see so many of you here. Let's move on. Today's video conference format we're using is, we're going to get to hear from two presenters. First, Dr. Diana Ionescu. She'll share her expertise in key actionable driver mutations, followed by Dr. Brandon Sheffield, who will share a MET exon 14 mutation case. Finally, both presenters will field a few prepared questions if time allows. And after each presentation, please feel free to ask questions, provide comments so we can learn from each other. The aim of these discussions is to help you overcome any challenges you might be facing at your institutions. Also, if you're not comfortable speaking, you can type into the chat or the Q&A functionality. A few final reminders before we get started. Your microphones will be muted until you raise your hand and are called on to speak in discussion time. And please do not share any protected health information or personally identifiable information about patients. Finally, CME and CMLE credit is available for this event, and instructions for claiming credit will be shared at the end of the presentation. Also will be available on the lung cancer website and will be sent to the email address under which you registered. So now let's welcome Dr. Diana Ionescu to today's Advanced NSCLC video conference. Dr. Ionescu is a consultant pathologist at BC Cancer, as well as a clinical professor in pathology at the University of British Columbia in Vancouver. She'll be sharing her expertise in key actionable driver mutations in patients with advanced NSCLC. I'll now turn it over to Dr. Ionescu to share her slides and begin.
Thank you very much, Dara, and thank you to the ASCP organizers of the ECHO project for inviting me to talk today. I'm very excited to learn that our audience is from all over the globe, and I hope that my presentation is gonna have something for everybody so we can, as Dara said, learn from each other. Okay, so I'm happy to talk to you today about the key actionable driver mutations in patients with advanced non-small cell lung cancer. These are my disclosures, and I will start with a short introduction. Both as oncologists and as pathologists, we have seen a huge change in the way we treat lung cancer. At the beginning of my training, the only therapy for lung cancer was chemotherapy. Throughout the last decade or so, we have seen advances in targeted therapies that improved patient survival. We have immunotherapy and a number of targeted therapies that shows a huge increase in patient survival. We can also see that the vast majority of these therapies, therefore called targeted, depend on a biomarker. The landscape of lung cancer treatment, and especially of non-small cell lung cancer treatment, it's very complicated nowadays. As you can see in this slide, as a first-line therapy and also on progression, the majority of the therapies depends on biomarkers. And there are many biomarkers, and we will talk about some of them today. About 35 to 50% of the patients with advanced non-squamous non-small cell lung cancer have a targetable driver mutation. You can see in this pie diagram that, as you know, the EGFR sensitizing mutation, it's the targetable driver mutation that is most commonly seen. And depending on the population that we look at, it accounts for approximately 17, or in the population where I work in Vancouver, Canada, approximately 21% of the non-small cell lung cancer. Following that, it's a population that shows ALK as a targetable driver mutation, and then a number of other mutations that account for lower percentages of non-small cell lung cancer carrying them. So I would like to go just a little bit over today's title backwards. So we will be talking about non-small cell lung cancer. And among the non-small cell lung cancer patients, we will be talking about those advanced ones. And as we know, about 70% of the non-small cell lung cancer do present as at advanced stage. Among those patients, many, as I showed on the previous slide, show driver mutations. Some of them are actionable. So those are the ones that we will be talking about today. And among the actionable driver mutations, we will focus on the key ones. And I will go in a minute over what key mutations are. Just to be a little bit more organized in our thinking about these driver mutations, we can think of them as being tested as standard of care, both in early stage for those hospitals that are lucky enough to have reflex testing performed at diagnosis, or in advanced stage patients, both treatment naive patients or in the resisting setting. There are also biomarkers that we test for as non-standard of care, and we will make the distinction in a minute. Throughout my presentation, because we are all coming from different healthcare systems across the globe, I would like to keep in touch that whatever we test for in non-small cell lung cancer depends not only on the science, but also on the fundings that are available to us. So there is a balance between the science and funding when it comes to biomarker testing. Ideally, medical oncologists really expect an ideal world, and they are asking us for this ideal world. They would like to have their patients present at the clinic, have a biopsy, have their pathology reviewed, and new generation sequencing done, all this in less than a week, with ideally molecular tumor board and results and treatment in less than 2 weeks. So ideally, all patients with non-squamous non-small cell lung cancer, regardless of stage, should undergo a comprehensive reflex biomarker testing at diagnosis with targeted next-generation sequencing, although this remains just an ideal future. The international recommendations for molecular testing in advanced or metastatic non-small cell lung cancer come from different organizations, expert bodies. And we probably as pathologists are mainly using the ones published by the College of American Pathologists, American Molecular Pathology Association, and International Academy for Study of Lung Cancer. But the newest one are those from NCCN. As you can see in this table, not all these bodies recommend the same molecular testing. They do agree that EGFR testing, ALK, and ROS testing should be performed. All there are in consensus, but then when it comes to other driver mutations, they are not really in consensus. NCCN is the one that recommends the most driver mutations to be tested. So practically, the purpose of biomarker testing, in my mind, is to guide personalized therapy available for your patients, for the patients that you serve as pathologists. So testing recommendations should therefore align with the current treatment algorithm and with the drug labeled at your institution. Very, very important to keep that in mind. So if we look again at the upfront broad molecular testing recommendations, we can distinguish standard of care biomarkers to test and emerging biomarkers. I'm not going to go on details and over these lists, and you can go back on the recording and maybe look at those again. But as I mentioned, sensitizing EGFR mutations, ALK and ROS rearrangements are the ones that are standard of care in most countries. Some countries, and based on some guidelines, BRAF mutation and NTRK gene rearrangements are also standard of care. And the emerging biomarkers include a number of fusions, RET, NRG1, MET, and also KRAS G12C and the EGFR exon 20 insertion mutations, which arguably some may actually move into the standard of care. And I will be talking about those today. So let's just start talking about the standard of care testing in treatment-naive patients with non-small cell lung cancer. EGFR remains the most encountered driver mutation in non-small cell lung cancer. And in this panel, you can see a timeline of the major development in EGFR mutated lung adenocarcinoma with the identification of epidermal growth factor receptor in 1975, and with a number of EGFR TKI inhibitors that were approved in different countries, starting with usually FDA in the United States, in 3 generations. So we have currently 3 generations of EGFR TKI inhibitors, but that's beyond the scope of this presentation. Also, I thought it would be interesting to look on panel B of the reported frequencies of EGFR mutations in lung adenocarcinoma based on geographic region. And you can see that, as I mentioned before, they are quite variable, with the highest number of EGFR mutation being identified in the Asian population. If you really would like to have one single diagram to understand EGFR, this is my favorite one. So most of the mutations in EGFR appear in the tyrosine kinase domain. And if you read this diagram, starting with the bottom half, we can see the mutations associated with drug sensitivity are mainly seen in exon 19 and in exon 21. Together, these are known as common EGFR mutations and account for roughly 90% of all EGFR mutations. Some other drug sensitizing mutations in EGFR are also seen in exon 18 and exon 20, but they are much less common. EGFR mutations are also associated with drug resistance, and you can see that on the upper part of this diagram. And the majority of EGFR mutations associated with drug resistance are actually seen in exon 20, with the most common one accounting for 50% of those mutations being EGFR T790M. So I think that gives us a very nice overview about where the mutations in EGFR are. Now, testing for EGFR can be done either as targeting the entire EGFR gene or part of an NGS panel. And I think we're all familiar with the advantages and disadvantages of these new technologies, so I'm not really going to go over them. The important part is that if we were to test the EGFR gene itself, we can detect all known, but also the novel mutations. However, from a practical point of view, inclusion of EGFR mutation as part of an NGS panel is highly desirable due to the higher sensitivity for detection and all the practicality of having the other driver mutations tested at the same time. So I think the scope of this particular slide is to really understand that although there are some advantages of single gene testing in EGFR, it is really time to break the silo and include and perform EGFR testing part of an NGS panel. I'm just going to shortly go over the new kid on the block, so something that's a little bit new in the field of EGFR testing, and that's EGFR exon 20 insertions. Those represent approximately 10% of all oncogenic EGFR mutations and are the 3rd most common class of mutations behind the canonical or the common EGFR mutations in exon 19 and 21 that I described before. There is also an unmet need in EGFR 20 insertions compared to the common EGFR mutations, because the 5-year survival for patients with exon 20 insertions, it's only 8% as compared to 19% in those with common EGFR mutations. So those patients have a 75% increased risk of death, an increased risk of progression, and 60% increased risk of shorter time to next therapy. Given all these, I think that we see how important it is for us as pathologists to make sure that we do test for exon 20 mutations. As the name implies, exon 20 mutations are seen in the exon 20. Because I don't have a lot of time to spend on this topic, I want to point out that those mutations, the exon 20 insertions, can be both resistant but also sensitive to the 1st, 2nd, or 3rd generation TKIs. And it is important for us to know that and also to specify in the NGS report in order to help our clinical colleagues identify those exon 20 insertions that may benefit or not as important from TKI inhibitors. So the reported frequency of the exon 20 mutations seems to be very variable in the world. But that may be also due because of the differences in testing. And it is likely that the true number of patients who have EGFR20 insertion in non-small cell lung cancer is actually underestimated. And here is again where I want to emphasize our role as pathologists. We talked about the two main ways to identify EGFR mutations, PCR or NGS. And we know that there is a decreasing rate of PCR testing seen not only in the US, as these data show, but also throughout the globe, and an increase in NGS testing. What I want to say about these two methodologies is that if only PCR is performed, PCR identifies only half of the EGFR exon 20 insertions variants that are identified by NGS. So if we were to state the problem in different way, is that if laboratories are performing PCR and not NGS, PCR may miss 50% of the exon 20 insertions. So it is important for the medical oncologist to know what type of test they ask for and also to understand the limitations of each of the methodology performed at their institution. Whether or not they don't have EGFR20 insertions in the biomarker reporting, if only PCR is performed, they should understand that 50% of these may be missed. I only have one slide talking about the liquid biopsy because of the time constraints, but liquid biopsy can be used at baseline to identify activating EGFR mutations. And practically speaking, really it's available when tissue biopsy harbors scarce tumor cells, or when time for a tissue biopsy is too long and the patients cannot wait, or invasive procedures for tissue procurement are contraindicated because of the patient's poor performance status. When it comes to the results of liquid biopsy, a positive liquid biopsy result for an actionable biomarker alteration should be regarded as a true positive. On the other hand, a negative liquid biopsy should be always confirmed using a tissue biopsy due to the still low sensitivity of this technology. So we're going to move on and talk about two other driver mutations, ALK and ROS1. And I chose to talk about them together, and you hopefully by the end of my presentation about these two driver mutations, you will understand why. So ROS1 and ALK fusions exist as distinct molecular subtypes of non-small cell lung cancer, and they do not overlap with ALK or with other oncogenic drivers. They are phylogenetically related, and both of them share the same clinical pathological features. They are seen more often in female patients, patients that are younger, in patients with Asian ethnicity, and in patients who are never smokers and have an adenocarcinoma histology. There are several methodologies that we can use to test for ALK and ROS1. The methodology used in the initial clinical trials is fluorescent in situ hybridization, or FISH, but we also can use immunohistochemistry, RT-PCR, NGS, being either DNA or RNA based. You can see that each of these methodologies have advantages and disadvantages. And the number one thing that I would like to point out about immunohistochemistry, while in some countries it can be used as a companion diagnostic and therefore the treatment can be obtained based on IHC result, in other countries based on the antibody used, immunohistochemistry it's still just a screening test. So if we look at the specificity of the antibodies used for ALK testing, the main two ones that are used are 5A4 and D5F3, high sensitivity, and also, and this is something that I would like you to remember, very high specificity. That means that a positive result can be trusted. It's specifically for the ALK rearrangement. So I showed you these two antibodies, and the ALK-D5F3 from Ventana, it's actually the antibody that's FDA approved since 2015 as a companion diagnostic for ALK-directed therapies. This antibody, it's interpreted and reported in a binary form, meaning it is either positive or negative. And this is the antibody based on which I said before, a therapy can be released by the pharmacies. So positive result is positive without any further confirmation. For the 5A4 antibody from Novocastra, the report is based on the intensity and percent positivity. So not any positive is positive, and the equivocal cases still must be confirmed with FISH or NGS. So let's look at a case. And through these cases, I'm also going to introduce the Ross immunohistochemistry just as comparison with the ALK. So we have a patient who had a lobectomy specimen for lung adenocarcinoma, and the immunohistochemistry report shows ALK being positive and Ross also positive. Is this report correct? I give you 5 seconds to think. So immunohistochemistry, ALK positive, Ross positive. So no, this report is incorrect because ROS1 cannot be reported as positive by immunohistochemistry. The reason is Ross immunohistochemistry, it's nearly 100% sensitive for Ross rearrangement, but its specificity, it's lower, ranging only from approximately 70 to 98%. In my practice, I think of it more like 70 than 98%. So I mentioned before that a positive ALK IHC, it's positive and you can act on it. That's not the case for Ross immunohistochemistry. Any Ross immunohistochemical stain, now I'm going to say positive, that's positive, that shows the brown staining, needs to be confirmed by other methodologies. So the current Ross reporting should be negative or equivocal. There is no positive word to be used in immunohistochemistry for ROS1. The translocation can be confirmed and reported as identified or not identified by FISH or NGS. So the treatment for patients with ROS1, it's available only in FISH or NGS confirmed cases. So now, if the immunohistochemistry report says ALK positive and ROS1 equivocal, FISH or NGS pending, so how do you treat this patient? Can you treat immediately? And the answer is yes. This report is now correct. It doesn't use the word positive on IHC ROS. And the medical oncologist should be treating this patient based on the ALK positive result, because the likelihood of ROS to also be positive, it's very, very small, because we learned previously that these driver mutations are mutually exclusive. And this is actually a picture from the Ottawa newspaper showing one of our first Canadian ROS positive patients who's actually still alive and doing well today. I do want to show you one slide of the ROS immunohistochemistry. And by the way, ALK immunohistochemistry looks exactly the same. It's the staining, it's cytoplasmic, granular, and usually when a case is positive, it's actually diffuse. And I want to emphasize again that for ROS, the specificity is lower than for ALK, and therefore it needs to be confirmed by other methodologies. If you want to become better in the interpretation of IHC, and if you want to avoid false positive ALK IHC interpretation, I strongly recommend that you go to this Canadian Quality Assurance website that offers free training and interpretation on the major biomarkers, not only in lung cancer, but in other cancers as well. One other slide before we move on from ALK, looking at ALK mutations versus fusions. So this is a story about apple and oranges. I mentioned that ALK, it's a fusion, but what if you get DNA NGS report that states that an ALK mutation is identified? The patient is treatment naive. What do? Actually, ALK mutation, it's different from ALK fusion. ALK mutation, it's usually an acquired resistant mutation in ALK positive non-small cell lung cancer. The mechanism of resistance to ALK are various, but one of the most common one is the presence of an ALK mutation. So for those of you that get a phone call from a medical oncologist stating that an ALK mutation is identified and they would like to treat the patient as a first line with an anti-ALK TKI, that's a no-no because the mutation is a resistant mutation and there are only fusions that we usually identified as rearrangements for treatment in first line. So fusions, I do not have time to go over fusions, but I would like to bring up the slide that I showed you previously and show that ALK and ROS that we talked about are fusions, but there are other emerging fusions that are important in non-small cell lung cancer. And among those, NTRK, RET are very important. I also want to point out the presence of another driver mutations that we will be hearing about shortly from Dr. Sheffield. And he will also probably cover some of the technologies that are available for the identification of fusions in general. So as pathologists, if you understand the principle of testing for fusions, that you will be able to talk about RET and NTRK and ALK and ROS when it comes to DNA or RNA testing. And Brandon will talk more about this. Just a warning when it comes to PD-L1 and its relationship with immunotherapy. So we talked about some driver mutations, EGFR, and EGFR is a driver mutation that predicts response to treatment. ALK and ROS also predicts response to treatment. You have to be aware that when we test for PD-L1, PD-L1 is not a driver mutation. It is a biomarker that predicts the likelihood of response. The response to treatment is not only based on the presence of PD-L1, but also of the entire concert or tango, if you want to, between the immune system and the tumor cells. So the only thing that I wanted to talk about the interaction between driver mutations and immunotherapy is that first line treatment immunotherapy, it's important to be given knowing whether or not a driver mutation is present. Because for patients with metastatic non-small cell cancer, the treatment should not only be based on PD-L1 expression level alone, but should be considered and should not be given to the patients that harbor EGFR, ALK, ROS, or other driver mutations. And approximately 27% of the patients with PD-L1 expression have actionable driver mutations. So from a practical point of view, if PD-L1 testing is available earlier than NGS testing, the medical oncologist should actually wait to make sure that the driver mutations it's not present. And that's the end of my talk. And I would like to just end by saying that as not only as pathologists, but as physicians in general, we acquire so much knowledge. But unless we really understand how to apply that in our daily practice, we won't be able to really come to a wisdom. And that's the wisdom that, unfortunately, all medical oncologists expect from us molecular pathologists to know when it comes to targeted therapy. So I would like you to really pay attention to understand the tests that we perform and teach the oncologists about what tests are available, how and when to order each of these tests, and to fully understand the report. There is definitely much more to talk about this topic, and that's why ASCP has an entire series dedicated to biomarker testing in non-small cell lung cancer. But this is what I had to say today, and thank you very much for your attention.
Okay, thank you so much, Dr. Ionescu. Let's open the floor for any questions or comments. Well, while we're waiting for any other questions that might come in, we have a question that we had prepared in advance that pertains to the topic. Do you think the role of the pathologist in NSCLC has changed because of targeted therapy?
I would say dramatically. I trained at the University of Pittsburgh and I always loved lung pathology. And when I started my career 15 years ago, I started as a pathologist at BC Cancer, which is a cancer agency. So I'm not seeing any non-neoplastic lung. And I was very, very sad at the time. But then very soon after, almost a year after I started working, targeted therapy in non-small cell lung cancer, and especially EGFR, and the importance of diagnosis squamous cell carcinoma versus adenocarcinoma and so on, came and became very important for practice. So that changed completely the way I practice as a pathologist in lung cancer. So I don't think of us as being only diagnosticians anymore. There is more and more a talk about therapeutic pathology, because I think we are now absolutely part of the team and actively involved in any molecular tumor board and in any therapeutic decision. And I think that knowing all this information about targeted therapy really empowers us as pathologists and makes us really the doctor's doctor in oncology. So yes, the practice has changed tremendously, and I strongly encourage everybody in the audience to feel empowered about this change and to become very active, to get involved in molecular tumor boards and in everything that relates to predictive biomarker testing and to targeted therapy.
Wonderful. Well, we'll move on, but as questions arise, please feel free to type them in or raise your hand. For sake of time, let's move on. Let's now welcome Dr. Brandon Sheffield to today's Project ECHO video conference. Dr. Sheffield is the Division Head of Advanced Diagnostics and the Physician Lead of Research at William Osler. Let's have Dr. Sheffield share his slides and begin talking about MET14.
Thanks so much. And sorry about that. I shared my screen a little bit too early. And
No problem.
Thanks so much. And that was a great presentation by Dr. Ionescu. And you're hoping just to build on this a little bit with one case report. And we're going to discuss another alteration in lung cancer. Here are my financial disclosures. And I thought we'd start with a case, and so often these cases start with an email from an oncologist to a pathologist, and I think this really puts everything in context. This was quite a recent case just from a few weeks ago, and here the oncologist is emailing their pathologist asking for testing on a squamous specimen. And this is, I think, a really important point, in that a lot of the testing strategies we have in lung cancer are for non-squamous, non-small cell. And one of the ways that the pathologist can be particularly helpful is in helping the oncologist achieve testing sometimes for those squamous specimens, particularly if they recognize a situation such as the patient's never had exposure to tobacco, or if there's other conditions such as they've progressed through multiple lines of therapy, or if the oncologist just has a sense that something might be off and is requesting that extra bit of testing. So in this case, the oncologist is emailing, I'm not Andy, I'm Brendan. Andy is the community pathologist, and he helped advocate to get NGS testing for this squamous cell lung cancer, which actually showed a MET exon 14 skipping mutation. And that is a type of alteration that, unlike many of the other drivers, is present in both adenocarcinoma as well as squamous cell carcinoma histologies. So this mutation was actually first described as being responsive to MET inhibitors like crizotinib or cabozantinib back in 2015. And we've since seen that now included in multiple guidelines such as NCCN or ASCO. Just briefly, the way this works, we know from our basic biology, maybe taking us back to our undergrad days for some of us, that genes are made up of exons, like these thick blue boxes, and then intervening regions, introns, that are sometimes shown as these thin black lines. And when a gene is expressed, the mature RNA has the introns snipped out, and it puts the exons close together, and that leads to transcription of a mature protein. But in a skipping mutation, if a mutation occurs right at that intron-exon boundary, that can mess up the way splicing occurs, such that the mature RNA is missing an entire exon, in this case, exon 14. And when we look at the MET protein, exon 14 translates into this juxtamembrane sequence, which is actually the regulatory domain of the protein, and it's what leads to the protein being destroyed. So when MET is made without this yellow box, or exon 14, it's actually immortal and lives on forever and leads to constitutive activation of growth, as well as invasion and other properties giving rise to cancer. And we know that these alterations can be exquisitely sensitive to MET inhibitors, such as a drug crizotinib. Even though we think of this as an ALK inhibitor, it was actually originally developed as a MET inhibitor. And so patients, even if they're bedridden in ICU, can have quite dramatic responses when you do identify this mutation in their lung cancer. And that was back from 2015, and now in today's day, we've got improved MET inhibitors such as capmatinib and tepotinib. These have a greater efficacy against MET exon 14 skipping mutations, and in addition, they also cross the blood-brain barrier, so they're more useful in patients who have brain metastases and in preventing brain metastases from patients who don't have them yet. We recently put out in Canada a guideline on the treatment of MET exon 14 skipping lung cancer, and this is a very useful guide for oncologists, but also for pathologists as well too. It has a lot of tips and tricks in terms of when to test and how to test for this particular alteration, and I think it'd be a useful resource if you don't have a lot of experience with these types of mutations. Here's another case, just to highlight the role of the pathologist here. This is a patient with stage 4 lung cancer. You can see multiple deposits in the chest. This is an Asian female with no previous history of tobacco use. And this particular case was tested with single gene testing. So you can see this is a PCR result for EGFR, a strong positive PD-L1, as well as our IHC for ALK, BRAF, and ROS. So a report like this, if it was issued to an oncologist, is essentially a prescription for PD-L1 checkpoint inhibitors. And the pathologist can really help steer the patients in the right direction if they recognize from time to time when a situation just doesn't sit right. So PD-L1 checkpoint inhibitors are great treatments, but in a patient who's an Asian female with no history of tobacco use, there's a very strong possibility that there might be an occult driver mutation or an actionable driver mutation. And when we go for the comprehensive testing, we see a MET exon 14 skipping. This patient was treated with a MET inhibitor and actually had a complete response. This was back in 2017, and the patient is still alive and well and continues to be on that same first-line treatment. When we look at the interplay between driver mutations and immune checkpoint inhibitor therapy, there's a lot to be learned here. So patients with EGFR, ALK, or ROS mutations will respond very well to EGFR inhibitors or ALK inhibitors or ROS inhibitors, but respond very poorly to PD-L1 checkpoint inhibitors. So to the point where actually, regardless of what a PD-L1 status is, PD-L1 inhibitors are contraindicated in patients with EGFR, ALK, or ROS mutations. Same goes for RET and likely NTRK as well. But in MET, we see there's this kind of intermediate level response where patients still respond very well to MET inhibitors, but there is some response to immune checkpoint inhibitor therapy. And it's not fully understood exactly how to best choose those patients, but the current thinking is that we should go back to our PD-L1 status, but also things like smoking history as well may be helpful in allowing the oncologist to choose the correct therapy. The same is true for BRAF-driven lung cancer. And putting that into the previous context we were talking about, things like EGFR exon 20 insertions, it's so important to identify those, even if there might not be an EGFR inhibitor with exon 20 activity. We really still want to let our oncologists know, because even if they can't get an EGFR inhibitor, these patients will do much better with chemotherapy than they will with immunotherapy. And again, it's really a double-edged sword, because tyrosine kinase inhibitors like ALK inhibitors or ROS inhibitors or MET inhibitors, they carry with them a risk of toxic pneumonitis, which can be life-threatening. Now, if a patient started on a PD-L1 inhibitor, say if they got a PD-L1 result before they got an NGS result or an ALK or a ROS result, then that PD-L1 inhibitor revs up the immune system and significantly increases the risk of life-threatening toxic pneumonitis. So the treatment will be the wrong treatment. They'll have a less chance of responding to it, but it'll also in a way make the patient allergic to the correct treatment. And to further exacerbate things, that heightened immune response will persist long after the PD-L1 inhibitor is discontinued. So we really want to make sure that good access to biomarkers for these, at least the ones on this list here, is provided in close proximity to a PD-L1 status. So going back to this report, there's something a little bit funny about it. And for those of you who might have seen a MET exon 14 skipping mutation before, you may have picked up on this already. But we're saying that there's no DNA mutation identified. And this mutation here is actually identified using RNA NGS, and it's identified as a fusion between MET exon 13 and MET exon 15. So it's an intragenic fusion identified in the RNA. Yet a more classic appearance to a MET exon skipping mutation would be that it's identified in both DNA and RNA sequencing. In this case, you can see the MET gene. There's no associated amino acid change, and the DNA alteration occurs inside of an intron, and that's how this is noted here in this nomenclature. The C stands for cDNA, so this is just coding DNA, and it's the 2,942nd coding base pair, but it's the -1 means we're just one base pair outside of the coding region. That's that splice site responsible for snipping out those introns, which has been altered, leading to the skipping event. And then we see in this case, once again, we're identifying that same alteration in the RNA portion of the panel. And this is actually a commonly described phenomenon. So this study very nicely demonstrates that effect, where when we look at a series of MET exon 14 skipping mutations, all of them are identified by RNA-based NGS, but only about half of them are identified by DNA-based NGS. So we know now that RNA-based NGS is going to be more sensitive for this particular alteration. In fact, the same thing is true for ALK, ROS, RET, NTRK, and other gene fusions too. So the modern day approach to NGS is going to be a more comprehensive approach where we're looking at panels that are powered to detect point mutations, copy number alterations, and fusions, which is typically done through RNA. So it is important for the pathologist to understand what's on the panel and how it's being tested. This is just one example of a panel. This is the Oncomine Precision Assay. And I'm just showing it as a way that NGS panel manufacturers can convey what's on the panel to the users. And a table like this is one of the most common ways and probably the easiest ways to understand, where we have in one box the DNA hotspots, and this is the traditional type of NGS. This is going to capture point mutations such as BRAF V600E, where one base pair is changed to a different base pair, or it's going to capture small insertions like exon 20 insertions in EGFR, or exon 19 deletions in EGFR. This will also identify those point mutations in ALK, such as alectinib resistance mutations or other resistance mutations after exposure to ALK TKIs. A different portion of the panel is going to get copy number alterations. So these are deletions of the entire gene or amplifications of the entire gene. And sometimes we see whole gene amplifications of MET, and these are also amenable to targeted therapy. Or more commonly, we all know about ERBB2 or HER2 amplifications, which typically occur in breast cancers or gastric cancers or carcinomas of the GEJ. Lastly, we're now seeing fusion panels being added on to these NGS panels, and that really increases the clinical utility because now we're testing for ALK fusions, ROS fusions, and we have that more sensitive detection of MET exon 14 skipping mutations, among other uses. So if your lab does have access to NGS, it's very important for the pathologist to be aware of what type of NGS is being used, whether it's using DNA or RNA, what type of mutations it tests, as well as what genes are included on that panel. And having a good working knowledge of that will really help you be conversant with your oncologists and help guide them and their patients towards the best possible therapy. So with that, I think we can go back to some further discussion. And if there's any questions about either this or the first presentation, we'd be more than happy to discuss them further. So thank you again, everybody, for your attention.
Wonderful. Thank you so much, Dr. Sheffield. Let's open the floor again. Maybe questions and comments will emerge from participants. We do have a question that is pertinent. How do you personally interact with medical oncologists, and how often?
So me personally, I find that I do molecular pathology as well as general pathology, and I do a lot of lung pathology as well. And I typically talk to one of our lung oncologists every single day. And I think that kind of dynamic is very important. When I say every single day, that's probably an understatement. We're constantly texting back and forth, emailing, phoning, and it's not uncommon that when they're in clinic, I talk to them in between patients when they go in and out of the rooms, and they'll even tell me who's coming up next sometimes, so that we're ready with their molecular results. I do think that the role of the pathologist is evolving, and that kind of dynamic and availability is really key to having a good lung cancer treatment team.
Wonderful. Looking here at time, we might need to move into closing at this time, but I want to thank Dr. Ionescu and Dr. Sheffield. We're now at the end of the ECHO session for today. I want to thank you all for your participation. And if you could please take 30 seconds to complete brief survey, which will appear immediately after the session on your screen. It helps us plan future initiatives. Also, please save the date, January 20th, He67 as a prognostic and predictive biomarker in HR positive, HER2 negative, early breast cancer, as well as January 27th, actionable results, turnaround time indicators for NSCLC workflows. Again, if you'd like to claim CME CMLE credits for today, you may access those links on the ASCP website. And in addition, we will email directions to claim those credits to the email address you registered under. So thank you, everyone. And this concludes today's session.